trauma and OCD. Many wonder how the two are even remotely connected. This is an essential question that needs to be addressed in research to find a treatment model for those who have a dual diagnosis. Researchers are starting to complete studies to try and gain more insight into the connection between these two disorders. I became passionate about understanding the connection between OCD and trauma because of my story. OCD runs in my family, and there is a history of trauma on my mom's side of the family. For me personally, my fears and intrusive thoughts center around childhood wounds and specific times when I felt powerless to help myself. So the question I am proposing today is, what is the balanced approach to treating co-occurring OCD and PTSD? One treatment model advocates for addressing your fears right now, and one advocates for creating safety and stabilization in the client's life first. What is the proper treatment model that addresses the need to combat the compulsions and relieve the anxiety you feel, and yet creating safety and stabilization before addressing intrusive thoughts or compulsions that are related to the traumatic event the client experienced? OCD is characterized by two main symptoms, obsessions and compulsions. Individuals who struggle with OCD have a difficult time letting their intrusive thoughts pass by. Their amygdala interprets the intrusive thought as significant, which leads to compulsions to relieve the anxiety they feel about the intrusive thoughts. Individuals who struggle with OCD often have a strong desire for certainty. They want to know for sure. They have a hard time letting intrusive thoughts pass by, and they participate in mental rituals, which make OCD difficult to treat. Clinicians who work with these individuals must understand the complexity of OCD. According to the DSM-5, PTSD symptoms include negative alterations in cognition and mood. This can manifest as the inability to remember important aspects of the traumatic event, negative beliefs about oneself, feelings of detachment from others, or a persistent negative emotional state. According to the DSM-5, alterations in arousal and reactivity are also associated with traumatic events. These can manifest as hypervigilance, exaggerated startle response, reckless behavior, problems with concentration, or sleep disturbances. With OCD and PTSD, there is an overlap of symptoms, including intrusive thoughts, avoidance, doubt, and engaging in neutralizing behaviors to relieve the anxiety they feel. Understanding the overlap of these symptoms is crucial for developing a therapeutic treatment model that treats both simultaneously. The gold standard evidence-based approach for OCD is ERP. Exposure and response prevention helps individuals struggling with OCD to let their thoughts pass by and not interpret everything as significant. As the clients are exposed to their fears, the therapist helps them sit with their anxiety and not give in to the compulsions to temporarily relieve the anxiety. The treatment model for PTSD starts with creating safety and stabilization first in the client's life. This is accomplished through helping them learn how to regulate their emotions. Once the client has demonstrated emotional regulation and has a strong support system and has a stable life, the clinician can help them process the trauma narrative. So I raise the question again of how do we treat OCD and PTSD at the same time? The OCD treatment model says these are just intrusive thoughts, so dive in and expose yourself to your fears. Yet the PTSD model says, wait, stabilize yourself. So what approach do we take to treating these both? A unified treatment model is essential to ensuring the client with this dual diagnosis receives the best care for both conditions. The clinician needs to be careful about any CBT techniques that may be damaging for those with OCD because traditional talk therapy doesn't work for OCD. In stage 1 of trauma treatment, the therapist can include elements of ERP, including working on mental compulsions that often consume those who struggle with OCD. Helping the client understand the sneakiness of those compulsions can help control the OCD. The therapist can also work on the shame that often presents itself with both conditions and help the client develop a stronger sense of self. Once the client is stable, the therapist can move to stage 2 and incorporate aspects of exposure therapy with trauma treatment. EMDR is proven to help with both PTSD and OCD, and this could be a beneficial therapeutic approach to address both conditions. In stage 2 of trauma treatment, the therapist can introduce an exposure hierarchy and work with the clients to expose themselves to their fears little by little. I'm curious to know if EMDR alone would be suffice to help with both conditions, or if exposure and response prevention is really needed as well for the OCD aspect of it. Both PTSD and OCD disconnect clients from the things that they love and the life they desire to live. Developing a proper treatment model will help them reconnect with their mind, body, and relationship with other people. Although the road to this is extremely tough, they can live a meaningful life ahead. It makes sense that there are times when these two conditions are present. OCD could potentially be a flight response to previous trauma, where the client is consistently on guard against anything that may be appeared to be linked to it. And OCD tends to latch onto everything the client cares about. So how do we help these individuals understand the threat is no longer present so they can live a meaningful life? This is an exciting time in OCD research, as researchers are looking at the connection between PTSD and OCD. According to researchers, there's currently no specific treatment model for both. This is an imperative research focus because the co-occurring disorder of these two is high. In general, therapists need to understand OCD treatment better. So for more information on OCD and PTSD, please check out the following resources that gave guidance for today's presentation on developing a proper treatment model for co-occurring PTSD and OCD. Included is more research on studies that are helping break the ground to